what we discussed on anti-epileptic drugs? Anyone? Last class anti-epileptic drugs উপরে কি হয়েছিল? Any anti-epileptic drugs you know? Sorry? Phenytoin, sodium. Any other? Sodium valproate. Or Levetiracetam. Or sorry? Carbamazepine. Or হলো আর কিছু? আচ্ছা। What are the important targets of anti-epileptic drugs? কোন কোন চ্যানেল বা রিসেপ্টর পরে কাজ করে? দাঁড়া, নাম্বার 1 সোডিয়াম চ্যানেল ব্লকার, তাই তো? কোন কোন ড্রাগটা সোডিয়াম চ্যানেল ব্লক করে অ্যাজ অ্যান অ্যান্টি-এপিলেপটিক ড্রাগ? ফেনিটয়েন সোডিয়াম। আর কিছু? আচ্ছা, নেক্সট, কোন ড্রাগটা ক্যালসিয়াম চ্যানেল উপরে কাজ করছে? কোন অ্যান্টি-এপিলেপটিক ড্রাগ ক্যালসিয়াম চ্যানেল উপরে কাজ করছে? হ্যাঁ, সরি, ইথোসাক্সিমাইড। আর কিছু? ভ্যালপ্রোয়েট। কোন ক্যালসিয়াম চ্যানেল উপরে কাজ করছে? টি টাইপ ক্যালসিয়াম চ্যানেল উপরে কাজ করছে। আর আচ্ছা, একটা হলো ক্যালসিয়াম চ্যানেল, টি টাইপ ক্যালসিয়াম চ্যানেল, একটা সোডিয়াম চ্যানেল। আর কোনো? গাবাই রিসেপ্টর, গাবাই ক্লোরাইড চ্যানেল কমপ্লেক্স, তাই তো? কোন ড্রাগটা কাজ করে? বেনজোডায়াজেপিনস বারবিচুরেট, রাইট। হ্যাঁ, গাবাপেন্টিন। আচ্ছা, নেক্সট চলে আসো, ফেনিটয়েনের কমনেস্ট সাইড এফেক্ট। মেকানিজম আমি জেনে নিলাম, সোডিয়াম চ্যানেল ব্লক করছে। মেকানিজম অফ অ্যাকশন, সরি, কমনেস্ট সাইড এফেক্ট। Hirsutism is a side effect, definitely. Commonest side effect. Huh? Nah. Sorry? Hirsutism is a complication, a side effect, definitely, but not commonest. Gingival hyperplasia is the commonest side effect. কিভাবে প্রিভেন্ট করা যায়? পিছন দিকে। হ্যাঁ, এটা কোন বই দিয়ে পড়েছিস? How we can prevent gingival hyperplasia caused by phenytoin therapy? No role of antibiotic there. কোন গ্রুপ অফ পার্সনদের বেশি দেখা যায়? Young personদের, and it can be prevented by maintaining good oral hygiene. It can be prevented by it, huh? Acha. Can you name some use of carbamazepine? One as an anti-epileptic drug, then other than bipolar disorder. আর কিছু? bipolar disorder আছে কি carbamazepine? bipolar disorder রুল নেই কিন্তু। Trigeminal Neuralgia, well, valproic acid, use of valproic acid. Number 1, epilepsy. Other than that, রোমাটিক কোরিয়া কোথায় পড়েছিস ভাই? হ্যাঁ হ্যাঁ, সরি, এটা বইটা কেন খুলে রেখেছিস? ওটা কি বই আছে? বইটা কেন খুলেছিস? বইটা কেন খোলা আছে রে? এটা কার বই? হ্যাঁ, use of valproic acid. Anyone? হ্যাঁ, শুনিনি রে, জোরে বল। বাইপোলার ডিসঅর্ডার একটা ইউজ, মাইগ্রেন প্রোফাইল্যাক্সিস। এটা কোনো রোল নেই রে, অ্যাটলিস্ট আমার জানা কোনো প্রমিনেন্ট রোল নেই। আচ্ছা, ফেনিটয়েন সোডিয়ামের আদার দেন এপিলেপসি আর কোনো ইউজ? ফেনিটয়েন সোডিয়াম আদার দেন এপিলেপসি আর কোনো ইউজ? কমন সাইড এফেক্ট অফ Carbamazepine, common side effect of carbamazepine. It's a dreaded complication, common complication. Huh? Hyponatremia, it's not a common complication, it's there. Hyponatremia caused by CIAD, inappropriate ADS secretion. Neurotoxicity. Okay. Drug of choice in trigeminal neuralgia. Drug of choice in trigeminal neuralgia. Carbamazepine. Good. Acha. Why Fosphenytoin is preferred over phenytoin in status epilepticus? Why Fosphenytoin is preferred over phenytoin? তাতে পড়তে হবে এগুলো, এগুলো খুব কমন ক্লাসিফিকেশন রয়েছে রে। Why Lorazepam is preferred over Diazepam in treatment of status epilepticus? জানতে হবে, এগুলো পরীক্ষাতে খুব ক্লাসিফিকেশন রয়েছে। অ্যান্টি এপিলেপটিক ড্রাগসের নাম জানতে হবে, ফেনিটয়েন সোডিয়াম পড়তে হবে, কার্বামাজেপিন, ভ্যালপ্রোইক অ্যাসিড, ঠিক আছে। তারপরে ম্যানেজমেন্ট অফ স্ট্যাটাস এপিলেপটিকাস আজকে দেখবো আমরা, এগুলো খুবই কিন্তু ইম্পর্টেন্ট কোয়েশ্চেন রয়েছে, পরীক্ষাতে বহুবার আসে। আজকে আমরা কিন্তু আফটার কমপ্লিটিং ফেনিটয়েন সোডিয়াম, কার্বামাজেপিন, ভ্যালপ্রোইক অ্যাসিড আমরা অ্যান্ড বেনজোডায়াজেপিনস, আমরা আজকে কিন্তু নিউয়ার অ্যান্টি এপিলেপটিক ড্রাগসগুলো পড়বো। So the first topic is Lamotrigine. Lamotrigine, as said here, it has carbamazepine-like action. So how does it act? It basically prolongs the inactivated state of sodium channel and thus prevents the repetitive neuronal firing. Again, it also directly blocks the voltage sensitive sodium channel and hence prevent the release of excitatory neurotransmitters, that is particularly glutamate and aspartate, and thus accounting for its broad spectrum anti-seizure activity. It can be used as an add-on therapy in refractory cases of partial seizure and generalized tonic-clonic seizure. Also can be used as monotherapy. It has also been found effective in the absence seizure, myoclonic seizure. It is better tolerated than carbamazepine or phenytoin. Newer anti-epileptic drugs, they have got better side effect profile, lesser drug interaction. So they are being more preferred nowadays. So it's better tolerated than carbamazepine or phenytoin. Coming to the gabapentin, as the name suggests, it's a GABA derivative, it's lipophilic. Now, what does it cause? Basically, it enhances the GABA release, but has got no action on the GABA A chloride channel complex. Again, it has been seen that it modulates a subset of neuronal sensitive calcium channel. As a result, there is decreased entry of calcium in the presynaptic neuron, causing decreased release of glutamate in the synapse, lowering the neuronal excitability. Now, it's the first line drug in the refractory cases of partial seizure with or without generalization. Refractory মানে যেখানে conventional anti-epileptic drug effective নয়. Now, it is mostly employed as an add-on therapy. Again, it is considered the first line drug in neuropathic pain like diabetic neuropathy, post-herpetic neuralgia. It is also used as a prophylactic drug in migraine and as an alternative drug in phobic states, phobias. No drug interactions are commonly seen with the use of drug, and when the drug is combined with other anti-epileptic drugs, the dose of other drugs need not be modulated. Pregabalin is the newer congener of gabapentin, similar pharmacokinetic, pharmacodynamic profile. It is particularly used for neuropathic pains like diabetic neuropathy, post-herpetic neuralgia, chronic regional, complex regional pain syndrome and others. Sedation with the drug is less marked compared to gabapentin, but poor concentration, rashes and allergic reactions have been noted. Coming to the Levetiracetam, is again a newer anti-epileptic drug used as an adjuvant medication as well as monotherapy in refractory cases of partial seizure with or without generalization. It generally binds to the synaptic vesicular protein SV2A and thus alters the release of excitatory neurotransmitter glutamate and inhibitory neurotransmitter GABA across the synapse. It also inhibits the N-type calcium channel in the presynaptic neuron, which may affect the intracellular calcium release there. Free of drug interaction, fewer side effects, increasingly used in partial seizure, myoclonic epilepsy, mainly as an add-on therapy for good tolerability. For GTCS and absence seizure, it is considered as a second-line adjuvant drug. Now, Topiramate is a weaker carbonic anhydrase inhibitor. Action, it prolongs the inactivated state of sodium channel. It also potentiates GABA action by a postsynaptic effect. It antagonizes glutamate receptors and neuronal hyperpolarization is caused via action on the potassium channel. So, it has got a variety of mechanism of action. As a result, it is indicated as a monotherapy as well as add-on therapy in refractory cases of partial seizures and GTCS. Also effective in myoclonic epilepsy and as an add-on drug in the absence seizure. It is also approved for prophylaxis of migraine. Zonisamide is again weaker carbonic anhydrase inhibitor, similar action to Topiramate, prolongation of sodium channel inactivation. Additionally, it blocks the T-type calcium channels and so has got some effect on the absence seizure. Indicated as both monotherapy as well as add-on therapy to partial seizure and has been tried in absence seizure, should be avoided in patients sensitive to sulfonamides. No drug interaction is seen with zonisamide. Lacosamide is increasingly being used as an anti-seizure drug nowadays. It is particularly useful as an add-on therapy in partial seizure with or without generalization. Action on the sodium channel prolongs the inactivated state and thus suppresses repetitive firing of neurons. No alteration in dose of companion anti-epileptic drug is needed because no drug interaction with other anti-epileptics. Tiagabine basically it blocks the GAT1 transporter which is present in the presynaptic neuron and thus it increases the concentration of GABA in the synapse and hence accountability for the anti-seizure effect. Currently it is approved only as an add-on therapy for partial seizure with or without secondary generalization. Vigabatrin or gamma vinyl GABA is basically inhibit the GABA transaminase enzyme which are present in the synaptic cleft and helps in the breakdown of GABA. So, the GABA concentration in the synaptic cleft is increased and thus it accounts for its basically anti-seizure effect. Effective in many patients with refractory epilepsy, especially simple or complex partial seizure with or without generalization and has got some effect even in infantile spasm. Approved only for adjuvant medication. Its use has been restricted because of some side effects like visual field contraction, alteration of color vision, paresthesia, behavioral changes, depression or psychosis. Now, these were the newer anti-epileptic drugs. Coming to the treatment of epilepsy, general principles. Anti-epileptic drugs, number one, it does not cure the disease. We just use to control the seizure. And but with the continued use of the drug, if the seizure can be suppressed, gradually the disease wanes off in some cases. So anti-epileptic drugs suppress seizure, do not cure the disease, but the disease may fade out after years of successful control. What is the aim? Aim is to control and totally prevent all seizure activity with an acceptable level of side effects. With the currently available drugs, this can be achieved in only about half of the cases. Another 20 to 30% attain partial control, with the rest being refractory. The cause of epilepsy should be searched in the patient. Why? Because if the cause is found and is treated, it should be treated. Number one, the choice of drug and the dose of drug depend on the seizure type and the individual patient. There is a trend to prefer newer anti-epileptic drugs because of better safety profile, because of lesser drug interactions. However, newer drugs are less well studied. Initiate treatment early. Why? As each seizure episode increases, the propensity of the another episode. Start with a single drug with a lower possible dose, gradually escalate the dose till full control of seizure or side effect appear. If full control is not achieved with the maximum tolerated dose of the drug given, then we can substitute another drug in place of the first drug. But how to substitute? We should gradually decrease the dose of the first drug and gradually escalate the dose of the second drug. For changing one epileptic drug to another, dose of first drug should be gradually reduced and that of second drug gradually increased till the second drug regimen is fully established. Use of combination drug is reasonable when the monotherapy fails with all the conventional drug available. Combining drugs with different mechanism of action is more acceptable, such as those with prolonged sodium channel inactivation with those which facilitate GABA release or facilitate GABA action. Pharmacokinetic interactions among anticonvulsants are common. Dose adjustment must be guided by therapeutic drug monitoring. When therapy with two drugs fail, what happens? To achieve adequate control, addition of third drug will not give more better response, does not improve the response unless the patient suffers from more than one seizure type. A single tonic-clonic seizure in a subject with no precipitating factor for development of epilepsy may not merit initiation of anti-epileptic therapy. যে পেশেন্টটা প্রথম এপিসোড অফ এপিলেপসি হয়েছে, যেখানে কোনো অবভিয়াস কারণ নেই কি এপিলেপসির কারণটা কি আছে, সেখানে অ্যান্টি এপিলেপটিক ড্রাগ আমরা আরম্ভ করি না, we wait. If the second episode is seen, we start the drug. Therapeutic regimen should be as simple as possible. All drug withdrawal should be gradual. আমরা যখন ড্রাগটাকে উইথড্র করব যে কোনো অ্যান্টি এপিলেপটিক থেরাপিকে, it should be gradual except in case of toxicity. কেন gradual? Abrupt withdrawal of the drug can precipitate status epilepticus. Prolonged therapy may be lifelong or at least 3 years after the last seizure is needed. Stoppage of therapy may be attempted in selected case. Factors favorable for withdrawal are: number one, childhood epilepsy, এখানে withdraw করে দেখা যেতে পারে; absence of family history, primary GTCS, and recent onset at the start of treatment, absence of cerebral disorder, and normal inter-seizure EEG. Inter-seizure EEG মানে দুটো সিজারে এপিসোডে মাঝে যখন পেশেন্ট কনসিয়াস রয়েছে তখন একটা ইইজি করা হয়েছে। The patient is fully awake, no seizure episode, then the EEG taken. That is called inter-seizure EEG. Even with these features, recurrence rate of 12 to 40% have been reported. Dose regulation must be guided by therapeutic drug monitoring. Why? Because number one, therapeutic range of concentration has been defined for many drugs. Marked individual variation in the plasma concentration of the drug is seen with the same daily dose. Compliance among the patients are poor. When women on anti-epileptic drug, if they conceive, what to do? Most of the drug or all of the anti-epileptic drug has got teratogenic effect. Now when a patient, when an epileptic mother, when an epileptic woman is pregnant, then on anti-epileptic therapy, then the drug should not be stopped. Why? Because if the drug is stopped and the patient and the mother develops epilepsy, that is also detrimental to the fetus. So, though most anti-seizure drug increases the incidence of birth defect, discontinuation of therapy carries a risk of status epilepticus. Fits occurring during pregnancy themselves increases the risk of birth defect and may cause mental retardation in the offspring. But what can be done? We can decrease the dose of the anti-epileptic drug cautiously. It may be advisable to substitute valproic acid by another drug, and definitely folic acid supplementation in the second and third trimester should be considered. Vitamin K supplementation in the last trimester should be considered to prevent neural tube defects and bleeding disorder. A seizure episode does not require any drug treatment. During GTCS, the priority is maintaining ABC, airway, breathing and circulation. The first priority is given to prevent injury due to fall or biting. The patient should be put in prone or lateral position. The head should be turned, patency of airway ensured. Attack usually passes off in 2 to 3 minutes, but the patient may not be roadworthy for a couple of hours. Now febrile convulsion. Febrile convulsion माने जोरे बोलो. In fever, basically it is seen in younger children less than 5 years. It occurs with the onset of fever and it recurs every time the patient develops fever. So what the treatment here is, the treatment is rapid control of fever with external cooling and paracetamol. So it is seen in children especially under 5 years develop convulsion during fever. Seizure may recur every time with fever and few may become chronic epileptic patient. Every attempt should be made to aggressively treat fever in them with paracetamol and external cooling. Now if a patient has come with febrile convulsion, then to stop the convulsion the drug of choice is per-rectal diazepam. So best treatment is per-rectal diazepam at the rate of 0.5 mg per kg given at the onset of convulsion. Intravenous preparation is used if rectal formulation is not available. So rectal diazepam is the drug of choice here. In recurrent cases or those at particular risk of turning into chronic epilepsies, intermittent prophylaxis with diazepam can be given at the onset of fever. Infantile spasm or hips arrhythmia, therapy of this condition is unsatisfactory. Most of the anti-epileptic drugs are useless. Corticosteroids afford symptomatic relief, but on the long term basis it has got more severe side effects. Clonazepam, valproic acid, Gabapentin may afford some relief. Now coming to the status epilepticus. Status epilepticus is a medical emergency. কখন বলবো একটা পেশেন্ট স্ট্যাটাস এপিলেপটিকাস রয়েছে? Either the patient is having continuous seizure for more than 30 minutes or the patient is unconscious in between two or more than 2 episodes of seizure. Then the patient is said to be having status epilepticus. It's a medical emergency because if the seizure remains uncontrolled, that can lead to grave complications. So when seizure activity occurs for more than 30 minutes or 2 or more seizures occur without recovery of consciousness, we say The condition is called status epilepticus. Recurrent GTCS without recovery in between is a medical emergency, and fits have to be controlled to prevent death and permanent disabilities. The first priority, maintain airway, breathing and circulation. So the first priority is to maintain patent airway, correct hypoglycemia if present, because it is one of the cause of seizure. Correct hypoglycemia if any, in case if it is responsible for the seizure. Maintenance of airway, oxygenation, fluid and electrolyte imbalance, blood pressure, normal cardiac rhythm, maintaining euglycemia and general care of unconsciousness should be done. Now what the drug of choice here? To Lorazepam intravenously is the first drug of choice. It is effective in 75 to 90% of the cases and produces a more sustained anti-convulsant effect than Diazepam. Diazepam action fades away after 20 minutes, but the anti-convulsant effect in case of Lorazepam, it lasts for around 6 to 12 hours. Diazepam intravenously was the standard therapy till recently. However, its anti-epileptic effect starts fading after 20 minutes and many supplemental doses are needed. It is also more damaging to the injected vein. So, Lorazepam is preferred over Diazepam. Now, after the patient has arrived with status epilepticus, we maintained airway, breathing and circulation, general care of comatose patient. Now, Lorazepam was injected intravenously, the seizure is controlled. Next, we have to inject Fosphenytoin, and Fosphenytoin has to be given with continuous ECG monitoring because there is a propensity to cause arrhythmias. So, Fosphenytoin under continuous ECG monitoring, it is a slower acting drug which should be given subsequently irrespective of response to Lorazepam. Lorazepam দিয়ে controlled হয়েছে কি হয়নি, that immaterial, but it has to be given. This may suppress seizure that have not responded to Lorazepam and pave the way for the long term treatment. Phenytoin sodium should be used only when Fosphenytoin is not available. Phenobarbital is another slower acting drug which can be used as an alternative to Fosphenytoin when Fosphenytoin is ineffective. It is also employed to maintain seizure free state over short term before definitive oral therapy is instituted. Refractory cases which does not respond to Lorazepam, which does not respond to Fosphenytoin, can be treated with intravenous midazolam or propofol or thiopenton, with or without curarization with full intensive care. Now some of the MCQs are there. Which of the following statement about anti-epileptic is false? Phenytoin and carbamazepine act by prolonging the inactivated state of sodium channel. এটা true কি false? এখান দিয়ে কে বলবে? Phenytoin and carbamazepine act by prolonging inactivated state of sodium channel. True ki false? True. Phenytoin and carbamazepine, they are basically block the sodium channel. Carbamazepine can be used in trigeminal neuralgia. True ki false? It is in fact the drug of choice. Diazepam is an anti-convulsant drug. True or false? True. Lamotrigine mainly acts by causing GABA-mediated chloride channel opening. True or false? It blocks the sodium channel. Take. Granulocytopenia, gingival hyperplasia, facial hirsutism. These are the possible side effects of which of the following anti-convulsant drug? Phenytoin. A patient on phenytoin therapy develops depression for which he was prescribed tricyclic antidepressant. He now complains of lassitude and his hemoglobin reading is 8 mg/%. The next step in the management of the patient is phenytoin একটা side effect রয়েছে megaloblastic anemia. Okay. So here MCV should be estimated. MCV will be raised. First, about mechanism of action of anticonvulsant. Ethosuximide, potassium channel opener, right or wrong? Huh? False. To true ki ache? T-type calcium channel blocker. Phenytoin sodium channel blocker, true or false? বাকি যেটা ট্রুই হবে। Diazepam facilitate GABA action, Gabapentin increase GABA release. Drug of choice for absence seizure. Ethosuximide has got action as absence seizure definitely, but the drug of choice is valproic acid. Okay, drug of choice in absence seizure is valproic acid. Drug of choice in complex partial seizure. In drug of choice in complex partial seizure. জোরে বলো। হ্যাঁ আর কেউ? হ্যাঁ Phenobarbital. আর Phenobarbital is rarely used nowadays for anti-seizure because of severe side effects. আর কেউ? Carbamazepine. Carbamazepine is the drug of choice in complex partial seizure. Which of the following drug is used in Status Epilepticus? Primidone, Carbamazepine, Lorazepam, sodium valproate. Lorazepam. All of the following adverse effects are associated with Carbamazepine except teratogenicity. দেখা যায়? হয় না? It's there. All anti-epileptic drugs have teratogenic effect. Neurotoxicity is decrease in ADS. Basically, carbamazepine increases ADS secretion, leading to water retention and hyponatremia. A patient trauma was diagnosed to be having febrile convulsion in the pediatric emergency. Which of the following can be used for the treatment of this patient? Rectal diazepam is the drug of choice. Raju, a 10-year-old boy, is having difficulty in learning at school. He has short lapses of awareness. এটা কিন্তু খুব important description. He has short lapses of awareness with eyelid fluttering that occurs every 5 to 10 minutes. এটা কি হতে পারে? এটা কোন টাইপ অফ সিজার হতে পারে? অ্যাবসেন্স সিজার। কথা বলতে বলতে থেমে গেল, আবার কথা বলতে আরম্ভ করলো। EEG studies, classical finding in EEG in the absence seizure. EEG studies reveal brief 3 Hz spike and wave discharges appearing synchronously in all the leads. Is the classical finding of in EEG in absence seizure. Which of the following drug would be effective but has the disadvantage that it causes sedation and develops tolerance? Valproic acid. আর কি কিছু বলতে পারবে? Ethosuximide. আর কিছু? Is clonazepam, because it has been seen with the use of clonazepam after 6 months the gradually tolerance to the effect is seen. The drug of choice here is valproic acid. Thank you.